Okay, is it okay if I will say this everything again and record it? I'm just fastly, okay? Is it okay, guys? Just I want it to be recorded, okay? Because I'm so sorry, I simply forgot, and I'm so sorry. Okay, let me say this everything again. I will not be very long. Just okay. So again and again, what do we have particularly here? This is the part of a liver, yes, as we remember, and as we already characterized, the liver is the second largest organ, as we said, yes, and it's approximately accounts for 2.5% of the whole body weight, and particularly the liver is accounts as one of not one is the largest glandular tissue and the largest gland in the body. Also, we remember that in the case of the fetal life, yes, we do have particularly the function of the liver is mainly the hematopoiesis, so the blood formation, and particularly in this case, it accounts even for bigger part of the fetal body, and particularly for 5% of the whole weight of the fetal body is literally comes on the portion of the liver. Now, what I told you that particularly according to how it is localized and where it is localized, as you can see here, yes, we said that first of all, that if we will subdivide the abdomen, and we can subdivide the abdomen into two ways, yes. One way is simply according to the median plane, so the midline and the part of a transumbilical one. And as a result, we have 4 quadrants, which are 2 upper and 2 lower quadrants, right and left, respectively, in both of these cases. Or we can subdivide it into the 9 quadrants, as you remember. And particularly here, we do have the formation of the 3 upper quadrants, which are 2 hypochondrias, as you can see here, right one and the left one. And in the middle, we do have a part of the epigastrial quadrant, or epigastrial area, simply to say, yes. So important thing is that particularly the liver itself, yes, is localized in the upper, mainly in the upper right quadrant, although you see here that it passes at towards the left one also. And in the case of these 3 quadrants, we can say that they are mainly that the whole right hypochondrium is simply occupied by the liver. Approximately the whole right hypochondrium is occupied by the liver. Then it is also passing to the superior part of the epigastrium, as you can see, as well as a tip of it or part of it is also passing towards the left hypochondrium, as you remember, yes. Now, what is also sorry, interesting here is that itself the liver, as you can see by its largest part, is localized on the right side, yes, but particularly between the ribs number 7 and the ribs number 11. So in this particular region, passes towards the midline, passes towards the left side, and here, as you can see, its tip is entering and residing somewhere at the level of the rib 7, sometimes in between of the rib 7 and 8. What is important, what we said is that because of its localization, that it is localized in the upper quadrants, yes, as you can see here, and particularly if we talk about the 9 quadrant subdivision, you can see that it is localized in the epigastrium and a part of the hypochondriums there, yes. So as a result, it is simply located in the close proximity to the diaphragm. As a result, even as you can see here, we can simply subdivide the whole surface of the liver into 2 main parts. Yes, this is particularly the diaphragmatic surface and a part of the visceral surface, which you can see particularly here in 2 different colors. So anatomically to see, you can see that according to the shape of a liver, we can have the part of the anterior surface, superior surface, posterior surface, as you can see, and the part of the inferior surface, yes. So as a result, we can simply say that the part of the diaphragmatic surface, which is convex, it's mainly associated with a part of the anterior part of it, posterior part of it, and a superior part of it and posterior part of it. And in the case of the visceral one, you can see it is mainly associated with the posterior inferior region of the liver. Okay, simply to say. Now, what is also important here to remember, as we said, that when we do have the standing position, yes, in the standing position, for example, simply in an anatomical position, we have some movement of the liver. First of all, because of the gravity, as we remember, and as a result, it is descending. And also, we do have particularly the. mm because of its close, again, localization referring to the diaphragm, again, the part of the movement of the diaphragm, it's which is dependent on its contraction and relaxation. According to that, sure, the liver will be also moving. Yes. So as a result, what we can see, yeah, here. So I'm sorry. Um, so as a result, when we talk about the surfaces of the liver, what we need to remember is that again and again here we do have the coverage by the peritoneum. Yes, do you remember? As a result, like if we are talking about uh, 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 intraperitoneal or retroperitoneal type of structures. For example, in the case of the pancreas, we said that it was mainly retroperitoneal. Yes, because we saw that it was just anteriorly covered, and that's all. But in the case of the liver, as you can see particularly here, that this region, the liver itself is the intraperitoneal type of the structure. Yeah. Why? Because that's the answer on this question is that what you see particularly here, that we have the coverage, let's like that, of approximately the whole surfaces of the liver by the diaphragmatic folds and by the peritoneal folds, and as a result you can see here the formation of the subphrenic recess as well as the hepatorenal recess. Yes, or as a result we do have simply these two layers of a peritoneum, which is mainly representing the part of the part of the visceral layer, the internal most, and the part of a parietal layer. Yes, so here and here. So in the case of a subphrenic recess, that's what you can see particularly here. You see that we do have the formation of the falciform ligament, which is the one demarcating the part of the right lobe and the left lobe of the liver from each other. Yes, as you can see here. Now, what is also interesting in this part is that the part of the hepatorenal recess has simply the several types, let's like that, of the names, which I want you to remember still, that particularly we can call it the part of the Morrison's pouch, this portion, as well as we can simply call it the hepatorenal pouch. Yes, so pouch, recess, whatever, like still it is the part of the diaphragmatic structures, which are mainly surrounding approximately all of the surfaces of the liver. Now, I'm sorry. Now, what is interesting in this case is that when we talk about the part of the liver, and we said that we subdivided into two main parts here. Yes, so these are particularly the right lobe and the left lobe. And as a result, we do have this falciform ligament as well as these recesses. Recesses are important to remember that if they are the peritoneal foldings, logically, there should be the presence of the potential space, or that's what we call simply the peritoneal cavity. Yes. So what does mean potential space? Yes, it means that it is not in reality the space. So the layers of a peritoneum are very closely associated to each other. Sure, they are not fused. I'm not saying about the fusion, but in between of them, we have on this small amount of the fluid, which is very much enough for the limited for smoothing the limited movements of the liver, like for example in the case of the excursions of a diaphragm, or in a case of simply the gravity type of a movements and so on. Now, okay, this one I said. Okay, the next portion, what we see here, if we said that yes, this is still the intraperitoneal type of the organ, although we said that we didn't say that the whole surface of the liver is covered by the peritoneum, but there is still in the area where, as you can see, this small area which we call bare area, as you can see, which is not that much covered by the portion of the peritoneum, particularly its visceral layer, as you can see. And this is the one which is the closest to the part of the diaphragm. So as a result, that structure, or that layer, or that region, simply that's what we call the bare area. Now, okay, we do have the surrounding of the peritoneum on the surface of the liver, most of it. We understood that, as well as we do have the formation of the falciform ligament. But why do we need the falciform ligament also? One thing, okay, demarcates the right lobe and the left lobe. All right, that's clear. But also the ligaments are simply for the attachment, yes? And as a result, the part of the falciform ligament is important for the attachment of the liver to the part of the anterior abdominal wall, okay? As well as, what do we have in this portion is that, for example, we have much more amount of the ligaments which are attaching so these are mainly the folds of the peritoneum, nothing else, yes? So, and as a result, because the liver is localized in more superior region of the abdominal cavity, it means that it's like, imagine it is suspended, yes, in the whole area, but it's suspended with the help of the peritoneum. And as a result, the peritoneum tries to attach the liver to the different parts, yes, in the surrounding. This is the logic of the peritoneum, yeah, as well as containing the blood vessels and the lymphatics, as well as the portion of the innervation. So in a case of a liver also, what we can find here is that, first of all, we do have, okay, the part of the bare area. We do have a part of the falciform ligament. As we said, this is the one which is helping us to attach the liver to the anterior abdominal wall, as you can see here, as well as, if you remember, when we were talking about the part of the stomach, we said that, sorry, when the stomach is surrounded by the part of a peritoneum, yes, as a result, it produces, on the lesser curvature region, it produces the, how do you call it, lesser omentum, and in the case of its greater curvature, it produces the greater omentum. Am I right? So what did we say about the lesser omentum? What was it composed of? Do you remember? Two ligaments, yes? So, and one of them is particularly the hepatoduodenal ligament, yes? So to show you here, if it's seen in this case, but not that much. Okay, here we do have only the part of falciform and the triangular ligaments, unfortunately. Here's the same, but okay. From the previous lectures, you would remember that we do have there the part of the hepatoduodenal type of a ligament, which is attaching the part of the liver to the duodenum, as well as we had the hepatogastric type of a ligament. Do you remember? Which was attaching the liver to the part of the stomach, yes? So these two ligaments were mainly producing the part of the lesser omentum. Do you remember? So as a result, we can see that, okay, the peritoneum helping us, one thing, attach the liver to the anterior abdominal wall, as well as attach it to the adjacent organs, such as stomach, such as duodenum, through the hepatogastric and hepatoduodenal ligaments, respectively, as well as the superiorly, we do have a structure of the diaphragm. And as a result, here we do have a part of a triangular ligaments, as you see particularly here, as well as here, this literally looking like a triangles, yes? So we do have here the part of the right and the left triangular ligaments, as well as we do have the part of the coronary ligaments, as you can see here. So mainly we can say that the bare area is surrounded by these ligaments, such as left triangular, the part of the right triangular, the portion of the anterior coronary ligament, as well as the posterior coronary ligament. Okay? So as a result, okay, let's see here. Maybe we have some picture. Just a second, did I say everything? Yeah. So as a result, that's how it looks like particularly again. So again, the portion of the bare area here. And as a result, you can see the portion of this coronary ligament surrounding it here, as well as the part of a triangular ligament here and here. Anteriorly, we do have a part of a falciform ligament, as well as more posteriorly, we will have the attachment to the portion of the stomach and the duodenum. Okay? Till now, is this clear or not? Good. So, okay, we understood that, okay, we have the surfaces, they are covered by the peritoneum, some of them are not covered by the peritoneum. Okay, we do have the parts of the ligaments which are attaching the liver to the different parts of the of the anatomical structure. So the organs, yes, intra-abdominal organs. But so as a result, the question is, if it's one of the largest organs, yes, it means that it will be like in the abdominal cavity. It will for sure have the communication, yes, by its different surfaces with the different types of the organs. Yes, simply to say. So as a result, on the portion of the visceral surface, particularly, as you remember, the visceral surface was associated with a part of the posterior-inferior region. Yes, because okay, in the diaphragmatic surface, we already saw mainly there is a diaphragm and all right, some anterior and superiorly localized type of a ligaments. But the part of a visceral surface, yes, the one which is literally exposed to the abdominal cavity, yeah. So in this case, it means that we should have some structures. So first of all, what are the structures in this case, and what are the ones where we have the which are exposed to the liver, or vice versa, to which the liver is exposed? Yeah. So I do have here, if I remember correctly, yeah, here I do have a list of all of the structures, as you can see, and then there's the lobes part. Okay, before the lobes, let's talk about these regions, and then let's talk about the lobes. So as a result, the structures that can be associated with it, let's think logical, yeah? First thing, what we saw already according to the ligaments, inferiorly, what did we have mainly? I mean, associated with the part of the stomach, yes, and the part of the duodenum. So as a result, the part of a less omentum, yeah, as well as the part of the right side of the stomach, as well as the superior part of the duodenum. Why superior? You remember the duodenum had the four main parts, yes? So superior most, particularly where you have the part of the hepatoduodenal ligament attached to, that will be the area exposed to the or oriented towards the visceral surface of the liver, yeah? I do believe it's logical. Yes, sure. At the same time, what other structures do we have there? If in the case of the pancreas, if you remember, we had the part of a transverse colon, and the pancreas is localized simply posterior to the stomach, then it means that here we also do have a part of a colon, yeah? But in this case, it should be the right side of the colon. On the right side of the colon, that high, that superiorly, we have the what? The turn or conversion of the ascending colon to the part of the transverse colon, yes? And as a result, it means that we have here the right colic flexure, okay? Plus, and Mohammed, you are correct, thank you so much. Sure, on the posterior part of the abdominal cavity, we do have a part of the kidney. Yes? So the right kidney, the right colic flexure, yes? As well as because the liver is the large, yes? So as a result, the part of the transverse colon, its right part, will be also associated with the liver. So right kidney, right colic flexure, right part of the transverse colon, yes? And if it's right kidney, then it's also, I do believe, right suprarenal gland, yes, or adrenal gland, yeah. So as a result, all of the structures, starting with the part of the stomach and duodenum and associated with them ligaments, which are hepatogastric and hepatoduodenal ligaments, yes, which are producing the lesser omentum, as you remember. So these structures are associated with the visceral surface of our liver, as well as more inferiorly, what do we have? We do have a part of the large intestine, particularly its large right colic flexure, as well as the right side of the colon, transverse colon particularly, as well as the part of the right kidney, as our colleague told us, and sure, the part of the right adrenal gland or right suprarenal gland. Yes? And one important thing what we shouldn't forget here is a part of a biliary system, particularly represented by what? By the gallbladder. Yeah? Because the gallbladder itself is not producing anything, as we know. It's just the reservoirs for the storage of the bile, which is produced with the help of a liver. And as a result, it's also localized in the close proximity to the liver, particularly to its visceral surface. Okay? Is that part clear or not? I do believe it was understandable. Yeah, very much. Oof. Okay. Now, yeah, here comes the parts of the lobes. Now here we have a nice picture for that, the portion of the lobes. And as we can see, first of all, what we can say in the case of a liver is that we have two main lobes. These are the right one, as you can see, and the left one, as you can see, yes? So two main. Out of these two, I do believe it's even clear from this schematic representation, the right one is the largest and compared to the left one in this case. The right lobe and the left lobe. Now, what is interesting is that from the, correctly to say, from the functional subdivision, okay, particularly on the right side of the liver and it, as a part of its right lobe, we have even, let's say like that, more subdivisions, okay, particularly as you can see by the right sagittal fissure, you can see here like the invagination, okay, as well as you can see the part of the porta hepatis. And by the way, the porta hepatis is the one where we have a portion of the entrance, let's like that, of the hepatic portal vein. And in this case, we do have two more type of the lobes, which are the quadrate, as you can see, as well as the caudate type of a lobe. Okay, so in the case of the caudate type of a lobe, okay, it is literally mainly, okay, localized more on the visceral surface. This is important to remember, of the liver, and as a result, it is associated and attached to the part of the gallbladder with the help of the ligament, which we call the ligament teres. Although I don't have it here, unfortunately, but there is a small band of the connective tissue simply in this case, okay? So you can see here the part of the quadrate lobe. That's how it looks like, the quadrate lobe, and the part of the caudate lobe. So as we said, in the case of the part of the caudate lobe, okay, so it is interesting. And why? Because itself from the name, the caudate lobe here, yeah, is like from the word caudus, yeah, it is more also sure localized on the more visceral surface, particularly on its lowermost part, you know, here. And as a result, here we do have the part, yeah, caudus means tail simply. And in this case, the portion of the, as I said, the part of the ligament that we have here, I said the part of the ligament, which is ligamentum teres, but that's not correct. The part of the ligament that we have here, this is the ligament venosum. And in the case of a teres, we have in the portion of the quadrate lobe, as you can see particularly here, okay? So the part of the quadrate lobe is the one which is associated with the ligamentum teres, and the part of the caudate one is the one which is associated with the ligamentum venosum. Please remember that too. And as a result, the part of the caudate, even caudate part, is also associated with a portion of the inferior vena cava. Why? Because it's caudate, it's more lower localized, and as a result, it has the exposure to the portion of the inferior vena cava. Okay. So, what is interesting here to remember, and what is important, to be honest, for me, yeah, is simply a subdivisions according to the lobes and according to the functional subdivisions, and literally that's it in the part of the lobes of the liver. Now, the next portion, what do we have? This is particularly the biliary system, as you can see, and the part of the biliary system. So, starting with a part of the general overview, as you can see here, of the biliary system. So that first of all, in the case of the biliary ducts that we have, yes, simply the main function of the biliary duct is to collect the part of the bile and literally project it from the liver towards the portion of the duodenum. And I do believe it's clear, yeah? So that's what we can see particularly in this picture. So this is the part of the liver, as you can see. This is a portion of a bile duct, yes, which is entering towards the or merging to the part of the pancreatic duct, main pancreatic duct, producing the part of the hepatopancreatic ampulla. So whatever. But what is important here is that, as we said, biliary ducts are mainly collecting the bile and passing it from the liver towards the portion of the duodenum. Important thing to remember is that bile, its production, okay? I'm not talking about secretion, I'm talking about production, is very much continuous, yes? Because the liver is literally making its function constantly, and as a result, we do have the formation and production of the bile. Although I do believe it's clear that not all the time there is the secretion of the bile towards the duodenum. Yeah. As a result, we do have, as we said, the storage for the bile, particularly in the region of the gallbladder, as you can see. So here we have a storage as well as the concentration of it. No concentration in this case, just because that in the case of the gallbladder, we do have the simply the epithelium, which is absorbing the excessive amount of the water from part of the bile, and as a result, we do have more concentrated type of a bile when it is coming from the part of a gallbladder. Yeah. So when we talk about the portion of the liver itself, you know that very well already from the histology that the portion of the hepatocytes are literally surrounding the small tube-like structures, which we call a part of the bile canaliculi, yes? And particularly these bile canaliculi are the ones which are collecting the part of the bile, and simply they are the ones which are draining the bile towards a larger type of the ducts, as you can see here, which are collecting bile ducts, as we call them. And then already from that particular region, they are merging into the formation of the right and the left hepatic ducts, as you can see particularly here. So by the merging of this canaliculi and then the merging of the large collecting bile ducts, we do have the formation of the right and the left hepatic ducts. Now, I do believe it's clear why we call it like that. Yes, what is right and what is left? Because the right one will be the one which is draining the right side or right lobe or right part of the liver. In the case of the left one is the one which will be draining the respective lobe and the part of the liver. Yeah. Now, as it comes out, as you can see, as these two ducts are literally coming out and leaving the portion of the liver, they start to unite, as you can see, and produce the common hepatic duct, as you can see here. So hepatic duct is the one, is simply, it contains the bile. Okay, it's nothing else. It's simply a bile duct, or correctly to say bile containing duct, and the one which is mainly produced by the merge of a right and left hepatic ducts here. You see? Yes. And then what you see here, as soon as it starts to merge with a part of the cystic duct, as you can see here, this one, this is the part of a cystic duct which comes from the gallbladder. You can see that as a result of this merge, we do have the formation of the structure which we call bile duct, the one which is then merging with the main pancreatic duct, and as a result, we do have the opening and the emptying of the bile towards the small intestine, particularly the part of a duodenum. Okay, so again and again, to say simply, the biliary system, what you see here, is literally composed of the ductal system, yeah, and where we do have particularly the part of the bile canaliculi. Then, as the result, we do have the collection of this bile canaliculi into the larger collecting type of a bile duct, and then we do have the formation of two hepatic ducts, right and left. Yes, which are merging and producing the common hepatic duct, and which is then next merging with the cystic duct produces the part of the classical bile duct, which we know, which is emptying into the portion of the duodenum particularly. Okay. Um, the bile duct, which we know, this classical type of a bile duct that we have, it is simply known also, or you can find it in a part of the textbooks, that we also call it the common bile duct. Now, I do believe it's clear why, yeah, because it's simply the produced as the merging of two ducts. That's why. So as a result, as it passes through through the portion of the lesser omentum, and as a result, it is simply entering towards the part of the second or descending region of the duodenum. Okay, anatomically, how large is the duct? It varies, to be honest. It can be like from 5 up to 12 to 15 centimeters, like something in between. Um, First of all, why? Because one thing, it's dependent on the age of the patient and of the individual. Sorry. Also, it is dependent on the merging, a point of merging of the common hepatic duct and the cystic duct. Okay. Because if it is very much at the beginning of the common hepatic duct, then it's clear that it will be longer. Yes, the bile duct, sure, here should be longer. Yeah. So if it is more lower or inferior localized, in this case, we will have sure much shorter type of the bile duct itself. Yeah. Now, anatomically, let's talk about the references, anatomical references of a part of the bile duct. Okay. And first of all, as you can see particularly here, that when it's descending from a portion of a liver, yeah, so down towards the region of the duodenum, as you can see particularly here, the how short it is or not, itself, the production of the bile is not that much dependent on the shortness, or I mean the length of the bile duct itself. But here maybe the problem with the secretion, you mean, yeah? Not the production itself. Because production is dependent on the portion of the liver rather than the part of the duct itself. So here I do believe there may be some clinical correlations, because one of the most common clinical correlation, this is cholelithiasis, or simply a gallstones, yes? Although it's not that much for the anatomical part, as this is the clinical correlation more for the type of the bile which is produced and what it is containing, you know. So that's why in this case, the passage of the bile in this case cannot be changing that much. Main idea, what it is composed of, and as a result, what type of the gallstones are produced. You know, like for example, the cholesterol type of a gallstones, which are one of the most common. I will talk about that as the part of clinical correlation today. Okay, so what I wanted to say, just a second, what do we have here? Yes. So as I said, the part of the bile duct, as you can see particularly here, as it starts to descend more inferiorly towards the descending portion of the duodenum. Sure, you remember here we do have a part of the head of the pancreas. Do you remember? As a result, on the head of the pancreas, on the posterior side of it, we can have some like a groove or invagination where the bile duct is residing, and as a result, entering and emerging towards the part of the duodenum. So, also interesting thing is that that here particularly, as soon as it passes on the posterior head of the pancreas, yes, that's where, as it passes it, that's where particularly we do have the merging. I will not talk about the merging too much because I do believe it's clear very much for everyone what we have, because I already talked about that in the case of the main pancreatic duct here. Yeah. So what is just simply to remember that in the case of a bile duct, we have the separate sphincter. Yeah, I mean separate from the sphincter of OD, which we have in the case of the ampulla itself. But here we do have the part of a sphincter of the bile duct, as we said already. Yeah, and that's where particularly we have the entrance towards the part of the ampulla. What? Just a second. Okay, let me finish this portion. There are not too much to talk about, and then I will go through the questions. Okay. So what is important here? Yes, this is the part of the arterial supply. So the blood supply, you can see it here or you can see it here, literally doesn't matter. And again, here comes the idea of the aortic blood supply. Yes, because abdominal aorta is the main thing what can give the any type of a branch in this case. And do you remember when we were talking about the, again, anterior surface of the aorta? That's where we have anterior unpaired, yes, type of a branches. Again, we have the first one, which we call the celiac trunk. And what was important about the celiac trunk is that, yes, it contains the splenic artery, contains the left gastric artery, contains the common hepatic, we said. Yeah? Then we said that common hepatic is subdividing into the hepatic proper and the gastroduodenal. So the hepatic proper, after that, simply subdivides into two portions. And these are the left and the right hepatic arteries. Do you remember? And particularly the right hepatic artery is the one which gives rise to the small type of the artery, which we call cystic artery. And the cystic artery is the one which is giving rise to the blood supply to the most proximal part of the duct, as well as itself, the right hepatic artery gives the smaller branches to the middle part of the duct to be supplied, and as well as the part of the pancreatico-duodenal arteries, if you remember the ones which we had there. Yes, these ones, particularly the superior pancreatico-duodenal artery that we have here, as well as itself the portion of the gastroduodenal artery. They are also giving rise to a very small branches, which are supplying the portion of the duct itself. So as a result, that's what you can see, particularly here itself, the portion of the cystic artery. Yeah, how it looks like. Although we said that not only the right hepatic artery, but as well as the gastroduodenal artery and its branches, such as superior pancreatico-duodenal arteries, as well as the right hepatic artery itself, all of them are giving rise to the blood supply of the whole portion of the duct and the gallbladder, as you can see. Okay, so that's how it looks like. The question is, and mainly we have it here in this picture, but don't we have it better in this case? Yes, this one is better to see, to be honest. Okay, so as a result, we do have the blood supply, okay, but we also do have the venous drainage. I mean, the arterial blood supply, but we also do have the venous drainage. What do you think? What can be the venous drainage in this case? I do believe it's clear. Yes, the same as in the case of a part of a liver. Yes, yes, I can repeat, sure. So the venous drainage, in this case, yes, that's true, towards the parts of the hepatic portal vein. Yeah. So the question is, what can be the drainage, venous drainage here? If what was the blood supply, as it was in the case of the pancreas, yes. So as a result, in this case, what should we have? Again, the same type of the venous drainage. Yeah. Again, the portion of the hepatic portal vein and whatever tributaries it has. Like, because if we talk about the portion of the pancreatico-duodenal artery, sure, we'll have pancreatico-duodenal veins, yeah, which are then associated to the part of the hepatic portal vein. So in this case, this portion is really very clear. I do believe it's understandable, yeah. But what is interesting for us in this case is itself a portion of a gallbladder, which you can see. For example, in this portion, yeah, here it is, how it looks like. So on the visceral surface, as you remember, of our liver, so the portion of the gallbladder, as you can see, is not a large structure, up to 10 centimeters long. And in this case, sure, it is residing on the visceral surface of the liver, yes? So what is interesting in this case is that according to that picture, you can see how close is the localization of the part of a gallbladder to the portion of a duodenum. You see? So it's so close here, particularly the superior part of the duodenum. I do believe it's clear that, yes? So as a result, that even during the, how do we call them? The operations, yeah, I mean the surgeries, yes, simply surgical intervention, we can find, like, when for sure when we are performing laparoscopic, or most commonly laparoscopic type of the intervention. In this case, first thing what we see, sure, is the liver, because it's the largest one, yes. As soon as we delicately start to elevate it, yes, in this case we can see the portion of the gallbladder and how it is very closely residing on the portion of the superior part of the duodenum. It's really they are really very closely attached to each other. Now, itself, the gallbladder, as you can see here, is literally the structure, which is the hollow structure, yes. So, and particularly here, you see that we do have a part of the fundus. Yes, this is the end, the rounded end of a part of a gallbladder, as you can see here. We do have more medial portion, which is the part of the body of a gallbladder. That's why we say that it's like the major part of it, or main part of a gallbladder here. As well as we do have a very narrow portion, which we call the neck of a gallbladder, as you can see. Now, what you see here is that particularly the neck is then opening towards the part of a cystic duct, yeah? So, the important thing that the gallbladder's function is simply nothing, just to get or receive the bile, concentrate it and store it, and only after that it can be secreted. Yeah. So why and how this particular concentration goes through, I do believe it's very much clear that this concentration is dependent on mainly the part of the reabsorption of the aquatic parts of water simply, and as a result we have the more concentrated type of the bile in this case. Okay, and as you can see, particularly here, the part of the neck when it enters towards the cystic duct, so if itself the part of a gallbladder is up to 10 centimeters in length, a portion of the cystic duct which is associated with a part of the hepatic one, you can see that it is approximately up to 5 centimeters or even shorter sometimes. You see? Okay, let me check if I said literally everything or not. Yeah, it's up to 5. Okay, 3, 4, up to 5 centimeters long. Okay, this is it for the portion of the anatomy where we have the accessory organs, all of them together. Now let's go through some questions. What do we have here? Let me see. Let me see, what do we have? Okay, let's go through the questions. If you have questions, please write them and I will go through them step by step, okay? Come on. I'm sorry. Okay, kidneys, yes. Okay, I do believe it was already before that. The production of the bile, we've talked about that portion. Yes. And Akshay is asking how the bile move from the hepatic duct to a gallbladder. What do you mean how it moves? I mean, what is the question? Could you please explain to me? Hmm? Nowhere, Nassim. In case of Nassim, and the answer on the Nassim's question is that it is not stored anywhere. I can tell you, because there is no place to do that. That's why the people who have particularly the cut